height is unilaterally. What's your belly dance? So bilaterally, it's going to give you an anterior pelvic tilt because it's going to pull up from the back and pull that pelvic rim up. Unilaterally, it can do a hip height where it's going to hike up one side in relation to the other. All right, so slide over and we'll find the spinous process. In the middle, in the middle, in the middle. So we can take that posterior iliac crest and drop down into the PSIS, the posterior suprailiac spine. And then you're going to find the back dimples, which is indicating you have the iliac crest overlying the sacrum, which is your SI joint. You step in from that and you'll start finding these spinous processes, L5, 4, 3, 2, 1 as you go up. And again, when we start looking at the thoracic spine on these spinous processes, we have that series of three, to where on our palpation, the region that we're covering becomes progressively more inferior. So palpation over T1, 2, and 3, and I'm actually pushing over the discs that are immediately below. On T4, 5, and 6, then I'm pushing on, I'm over the vertebral bodies of the vertebra below, and then 7, 8, and 9, I'm actually over the disc below the vertebra below that vertebra that we're palpating. It's a lot of prepositions. It's a lot of blows. Look out below. So, transverse process. We got to play with these a little bit last time too. Lumbar region is by far and away the easiest because the ribs kind of protecting the thoracic region. So if you come, find your rib cage, and slide down to the soft squishy and start playing with the kittens. And then you have the kittens down in here. And you work your way up, you can find the rigidity of those transverse processes. So you can feel those from either side. And again, you can use those to, if you find them and then put your thumbs on them, to kind of feel how much mobility you have within those, within a little bit of rotation for those spinous process, for the vertebra. You good? Nope. Okay, so if we start out here, we find the kittens. That's what I heard. I just keep going. All right. So if you start out, so find that last rib, come in below. So last rib, come in below. There you go. And then you work your way up. And when you get right in here, all of a sudden it's hard. Okay, so that's where these are. And so if you put your fingers bilaterally, and you're looking at about that width. So I mean, those vertebrae are pretty significant. So spinous process is there, and then their transverse are there. So you can come in and feel a little bit of rocking. And she's a little tense on that extension, so her back extensors are a little tight right now. She's like, "Quit this up, man." I'm the dog person. No. Yes. Okay, so you come out here. So start out wide.
It's also, I'm thinking I'm pressing it. Sore back muscles, I'm sorry.
I'm actually not sore.
¿Qué? Es que no, ya no sé si sí dije eso o no. Y se nos dije, ¿qué?
It's not.
Sí, él sabe. Es que así les digo.
Entonces con los dedos hacia adentro, hasta encontrar el profesor.
Está duro, está duro.
And then you can kind of get over it. You feel for rotation of that as you go segment by segment. And see how that functional ability of each of them. All right, so laminar groove. It is that canal that runs within. So the transverse processes come out here, the spinous process there, so it creates a gutter in between them, which is your laminar groove. So the lamina connects the transverse and flows into the spinous process, so the laminar groove is that connection piece, but it creates a gutter through which we run a couple of muscles. So if you find those transverse, then you find the spinous. That little space in between is all, for the most part, soft, squishy muscle. Until somebody does something like really make it mad, and then it's not. Okay, muscle group, the erector spinae. So these are your spinal erector muscles. There's 3 of them that make up this group. These 3 constitute the mass movers that pull our body up. So they're going to start from below down in this region with a very fat kind of banding and reach up so we can grab this and lift our bodies up. So if you find the transverse process in the lumbar spine, find the spine, find that laminar groove and set your fingers right there. And if your individual, your patient, your buddy, your friend, your pal is relaxed, and then all of a sudden you have them go into a back extension, you will feel those spinal erectors completely fire, get taut, and fill up that space. And all of a sudden it becomes much more rigid as those muscles contract and become taut.
Oh, nice. Okay, you can relax.
Yeah, that I feel from
All right, so first one we have is iliocostalis. So the iliocostalis goes from the ilium, and then plus into the sacrum, but the ilium, up into the costals, into the ribs. So iliocostalis, it's the most lateral of the muscles. Spreads out, fans out, grabs on the ribs, and it's getting leverage to grab the ribs and pick you up.
How come your PowerPoint's in a completely different order than the one online?
Oh, because I didn't like it, and then I just recycled my browser. Recycled my Blackboard page,
Okay.
and didn't update all the files. You know, sometimes you look at things and you're like, man, I need to fix that, and I'll do it later, and then later just never ever comes. So I do it just to mess with you guys. Everybody needs a hobby. Mine's making your brains hurt.
Ooh, party.
Longissimus. It's long. Yep, there you go. It's long. Every now and then you'll realize that even on my end it's somewhat out of order, so it's okay. So, in Mark's part, so you'll find that this muscle set, it goes over that laminar groove, but it also is superficial to the transverse processes. So we go iliocostalis out wide, longissimus next, and then the inside is spinalis. And spinalis is largely going to fill up the inside of that groove. Now you can recognize that we have, so spinalis also becomes semispinalis. So it's a slight name change, but if you see semispinalis, largely it's just looking at the section of it higher up. And then within each of these, you can clarify a portion as well and say spinalis thoracis, semispinalis cervicus. It's because you're talking about that muscle within the region of the cervical spine. So grandiose long names, we can easily say that these muscles as a whole run all the way, but you can very easily see that they're segmented as well, and we can reference them within the segment of the spine that we're working. So don't let that throw you when you start seeing other pictures. We've done PSIs. Vertebral column. Okay, the intrinsics. There's 2. Crazy, crazy. So these guys are only going 1 to 2 segments. They aren't going far at all. Rotatories. And multifidi. So rotatories, 1 segment, transverse process up into the body and the spinous process of the segment above. And so sequencing the firing those is going to give us rotation. The multifidi tend to be a little bit longer. They travel a little bit more distance. They might skip 2 segments, perhaps. The big piece about multifidi is their presence within that sacral and distal lumbar spine. So multifidi become more of, well, less of an intrinsic and more of a significant stabilizer in that lumbar spine. There's research out there that shows that the cross-sectional area of the multifidus muscle in people with chronic back pain is about 50%. So what does that mean? It means that if you get back pain and the doc tells you to lie down, take it easy, let it heal, let it rest, and it stays hurting, and so you keep babying it without using it, that muscle atrophies. We're getting to a point that that muscle isn't able to do the work that you're asking of it, which is just going to aggravate it to try to use again, and that cycle continues. So there isn't a best solution in my world yet to tell you this is the rehab plan you should have for this injury set, but rest typically fails to resolve many issues. But intrinsic, small guys, they go all the way up, all the way down. Rotatories, multifidi. All right, traps. We will talk traps again when we get to upper extremity, because they are very much a scapular stabilizer. They stabilize the shoulder blade in place so that the arm can work off of it. But it's also a very prominent muscle that we need to consider in referencing shoulder function, but neck movement as well. So it's going from the occiput all the way down to T12. That's a long stretch of real estate. So that's the origin. Its insertion point is that it all blends out into this point on the spine of the scapula. So let's make sure we find those landmarks. All right? So the superior end, we've got the occiput. So it's going to run bilaterally out into the spine of the scapula, which is currently rotated with the way she's sitting. It's all good, man. It's your comfort. So I got you the pads. You should make her not be on a pad because she said she didn't want one. So it's going to come and kind of bow out this way and then down into T12. So when we start referencing how the traps work, we'll talk about an upper, a middle, and a lower trap section, because each of those is going to have a unique pull on the scap and have a unique movement within our range of motion.
So the origin be the occiput and T12?
So occiput through T12. So it's going to be this landmark all the way down. So spinous process is on each side. The spinous process all the way through T12. And then its insertion is going to come out to the spine of that scapula. Okay? So base of the cranium, we got superior nuchal line, which is the ridge that we have on the occiput. Is that ridge that comes straight across here. Superior nuchal line. And why do we have nuchal line? Well, we also have that nuchal ligament, which comes from that same location and down, that covers our spinous process, is C1 through C7. Our whiplash ligament, right?
Yeah.
Good. So again, find ways to kind of correlate some of these words to the pieces that we're looking for. So the numbers you want to hold on to. All right, so let's rewind, switch partners. I'll come back to the traps, because if we're doing the neck, it's a little easier. Seeing as how this person has a lovely, squishy, happy face pillow that I don't have for you. It's easier to kind of do that seated with your head tilted down, so we can kind of work through some of those pieces. So let's go back through and kind of find some of these landmarks.
Oh, let me switch you real quick. Oh, what are you saying?
We'll do the same, find the same palpations, we'll be good to go. So, if you can reach forward, you can find the ASIS. Leave your hand in a C shape. You can wrap your fingers around that iliac crest as you work your way up. And again, recognize that it is more caudal, it's more up towards the head. It's higher up in the back than it is in the front. And if you keep palpating around, you should find the PSIS as well. posterior superior iliac spine.
I know it's a gorge. Okay, go. I know.
Back.
Those are ribs. Those are my ribs.
I tried that in my neck.
Those are my ribs.
Yeah, it's no good. Alright. We good? Got it? Cool. So find your kittens. Find the soft squishy side. And as you go up, you're going to find the distal ribs. The easier way is to find a few of the ribs that are higher up and then work your way down until all of a sudden you don't feel them anymore. So you can find those two distal floaters.
Now I feel like I did say kittens. Now I don't know.
You can always go back and check.
Oh yeah, we'll check.
There's enough audio recordings going on here. We'll be good to go. So you find those two inferior ribs, 11 and 12. And then just below it, well, underneath those deep, and then below is the kind of the exposure of your kidneys down below. Now, going from that space in between that 12th rib, so in the soft area, and work your way back towards the medial area, you'll find where all of a sudden it goes from soft to hard, and that's where you're hitting transverse processes. So you're going lateral to medial in between that 12th rib and that posterior iliac crest, and you can work your way back into finding that transverse process. So that's one way to go about it. Now, if you find it on each side, then you could put a finger on each side and kind of rock, and you should feel a little bit of give segment by segment. And this is one of those things that it helps to train your hands to be able to do, especially those of you who are going to PT school, because this is kind of
It's a big thing.
being able to assess restrictions within the spine is definitely something that will help your practice. Good? All right. Now, filling in that space on the medial side, we've got Quadratus Lumborum. Iliac crest up to the 12th rib. Anterior pelvic tilt, belly dancer muscle, good to go. Spinous processes we're good with. Transverse processes we found. Laminar groove. So find those transverse processes, find the spinous process, and work your way up, and you can find that groove all the way up to...
Wait, so for this one, it's... The picture confuses me.
Okay, so the highlighted area, so it's kind of a red band. So these are your spinous processes, they left them in gray, black, whatever. And then this is the tips of your transverse processes, they really left those alone too. So they kind of showed that red band that just sits right in between them. So the lamina connects your transverse processes back into your spinous.
Okay.
And so from that, it's kind of creating a little bit of a...
Okay.
And so that's what it's referencing, is that space, that gutter. Okay? All right. Now, working with that gutter, we go in and find the Erector Spinae. So Erector Spinae, have the person go find that groove, slide your fingers in it, nice soft tissue, have them do a back extension, and you'll feel those muscles pop up.
Mm-hmm.
Iliocostalis muscle goes from that ilium and the sacrum up into the costals, the ribs. They'll grab wide and pull you up. Underneath that is longissimus. Longissimus runs kind of over the transverse processes, and then spinalis is going to run through that gutter underneath longissimus, which makes up that Erector Spinae group. Multiplicity rotatories, trapezius. So find the superior nuchal line. That nice big fat ridge on the base of the occiput. And I think at this point, if you're good with what we found, then we can transition to where I have you seated and we work on the neck from there. I mean, I know that disrupts you and gets you out of napping position. But, hi, how's it going? So, gotta get up. Wait till we get in with this. This is the good part. I can walk you through doing some neck releases. This is good. I prefer necks. This one. Trapezius is the most superficial muscle. Do a shoulder shrug. So what I'll have you do is, stay with your partner. So we'll do palpations. So one person stays here, the other person's going to poke and prod. If you would like to be lazy, then you can actually have your partner turn around and face the wall, and then you sit on the table, and then they're just sitting right in front of you. It's entirely up to you. So, have it do a shoulder shrug. So sit upright, do a shoulder shrug, and you'll be able to see that trapezius muscle pop out, much more visible. So that's it, right there. Nice big band. Got that?
Yeah.
Cool. So shoulder shrug, and from that you're going to have this band right there. Yeah, nice big fat muscle that's going to come all the way up into that nuchal line, and it's going to follow this path right here, and then trace itself down. This, but that's the superior edge of it, which is nice big fat. Okay? Something to pay attention to is that the fiber directions shift as you go through. So if you're going to do a massage and try to work out some kinks on somebody, then recognizing the direction those fibers run is kind of a good idea. Because you want to know if you're doing cross-friction massage going across the fibers, or if you're doing like kind of a deep tissue to where you're going with the fibers and stripping them out. Basic cranium we found, superior nuchal line we found, Spinalis Capitis, Spinalis Capitis. So sitting deep to that, we have two sets of muscles, Spinalis Capitis, and again, semispinalis is an extension of that spinalis, and capitis is the capital region going up to the skull. So capitis is referencing things that are attaching high up, C2, C1, into the occiput. Cervical kind of hits the principal region around the primary cervical spine through here, and then thoracic will get down. So don't be thrown by the term capitis. This is fairly directly underneath the traps, and so it's not something we can really palpate or get to uniquely from the muscle that's superficial. Spinalis Capitis is a little bit different though. You'll notice that as it's coming off of C7 down through about T3, T4, that's a little bit of a guess, I'll double check that. That it's coming up and wide into the nuchal, superior nuchal line up and through here. But it splits out, so it's giving us more leverage to do lateral extension with rotation. Now that one we can find fairly easily. So if you get them to, if you have the person shrug the shoulders again, so you can find that, the trapezius, then you can follow that all the way up into here, all the way up into the superior nuchal line. If you come just lateral, then that insertion point is your Spinalis Capitis. So where you feel the cords up through that laminar groove is largely your upper traps sitting on top of everything. But yes, as you come out, then that muscle is going to band up and insert up into here, and that's going to be. So it's a little more tender, but sometimes you'll find that if that tension headache isn't sliding into that superior traps, if you come out into Spinalis Capitis and hold pressure, then life is, well, you can relieve some pressure. Now, let me take a moment and kind of, there's different massage techniques, different approaches within manual therapy. Some of them are far less comfortable than others. One way to kind of work through and find things is if you take your finger and you kind of slide through a muscle until you feel a restriction. And then you just hold pressure. A bump. A thickness. It's not a bump like I'm hitting a table. It's more like all of a sudden it's more dense because it's a contracted muscle, but loosely, like certain fibers are contracting, not the whole thing. And so you can gently kind of work your way up. Now there's couple different kinds of those regions. Some of them is damaged tissue, where the fibers around it are contracting. Those are typically the ones that we want to get at. because if those fibers are contracted, we don't have blood flow that's getting to that region very easily at all. So to hold and put pressure causes a bit of ischemia. What's ischemia? Lack of blood flow. Lack of oxygen supply. So if we hold pressure, much like if I hold pressure on my fingertip and it turns white, if I hold pressure on that muscle, then it prevents blood flow, which prevents oxygen, which prevents energy. So we're kind of starving it. But if we starve it, then it can't contract anymore. So after a few seconds of holding that pressure, we release. It has to release as well. New blood gets in there and typically helps heal it. Now, the position Rachel's in right now is going to be a little uncomfortable. If you put the muscle on stretch, then it's going to be very tender to do that kind of massage on. So another way to do it, if you don't mind. So if we can come up, and there will be a spot right there, almost always, C4, C5. People like carrying a lot of load right there. Now again, if she's on stretch, then she's going to have some issues. That's going to be enough to make her wince. There's a technique called positional release therapy. And the whole concept is that this kind of pain is unnecessary. You're welcome. So if you actually find it, and then tilt her and shorten the muscle, hurt less?
Yeah.
Yeah? Still feel like I'm holding the same pressure?
Yeah.
Yeah? There you go. So the whole idea is, I'm still holding pressure on that muscle. I'm just not putting it on stretch anymore, so it's not going to trigger where it hurts quite so much. And then when I let go, it's still going to feel like it removes a couple pounds of pressure on her head. Helpful? Hurts less.
Yeah.
I didn't learn that till later in life. I caused a lot of people a lot of pain in my life. Try to help you out there a little bit. So the second place, though, is, again, the first place that we're kind of hammering on, pushing on, is damaged tissue or high stress where it's trying to protect itself. The second kind of place is your trigger points, or where nerve roots, or nerves come in and innervate the muscle. So there's another spot, like right in here on the top of the shoulder, that almost anybody can find. You touch yourself and you're like, oh, that's... To hammer on those spots is really hammering on where the nerve is hitting that muscle, and it's already hypersensitive. So you can beat it up, it's always going to hurt, and it's rarely going to do a whole lot for you. So it's super tense because everything else is super tense. It's making all of this higher up contract and do too much. So if you can relieve the source, then this will calm down as well. But beating up on where the nerve hits is rarely ever going to leave you with... Find it?
No, it just feels really weird when she was pressing.
Oh, yeah, getting up into this region is... This is... They'll reference this as kind of surgical no man's land. This is your brachial plexus comes out. It's a whole lot of nerves that come in underneath that scapula. And then your arterial supply that goes out into your arm also comes in underneath. So nobody likes pushing. It's kind of, like, especially when you go right on top of that.
Yeah, isn't that your pressure point?
Yeah, oh yeah. Because there's a lot of nerve. Yeah.
Press there.
It's like, hey man, this smells real bad. Don't smell it? It's like, that hurts. All right. So, trapezius muscle runs up into the line lateral to it, and we're getting into kind of a peeking into where that Spinalis Capitis kind of resides.
Yeah.
Now, deep under that, there's a whole group of muscles called suboccipitals. And I'm going to leave it at that, because it's not something that I'm ever going to be able to get you to releases on, work with, differentiate from one to the next. Suboccipitals means it's under the occipital bone. They're assisting with knotting, with rotation, with stabilization of C1 and C2. All right, now two more muscles that I'm going to have you focus on. One is called Sternocleidomastoid. We would abbreviate that one as SCM for short. So the name tells you where it goes. Sternum. and clavicle, which is cleido, and to the mastoid process, which is behind the ear. There's a base of the skull, a little bit of a projection that comes down. So if you tilt your head, turn your head in, turn your head to your left shoulder, and then tuck your chin in, then you'll have a muscle pop out that runs diagonally from behind your ear down towards your sternum. And if you tilt your head sideways, lateral bend it, it should pop out even more. Got it? Okay? Your head's going to fall off. Your head's gonna fall
Cleido,
off.
what were the EMs?
Sternocleidomastoid, mastoid process. Sitting underneath that is your jugular vein. Right in here. There's a whole lot of stuff that runs right in through here. You can do releases on that as well. It's just not the most comfortable thing on the planet. Definitely feels good when they're done, but for two reasons. A, it felt so bad when they were doing it, and B, because we're hopefully releasing some tension within it. But super tight SCM is going to be a bit of a problem. And then coming off the transverse processes in the sides, and then down into the first and second ribs. So they're helping to lift things up, elevate the ribs, especially with forced inspiration. So we'll get to them later, but there's a group called your scalenes, anterior, middle, and posterior scalenes. So where you find SCM, if you come down, and again, it's in that kind of a spot over the collarbone that is a bit uncomfortable. So find SCM, just go slightly posterior, and then drag your fingers down, and you're pretty much rating right over your scalenes. So SCM runs right through there. So SCM's right through there. So scalenes are seen right up and through there. Mm-hmm. That gap right in there as it goes up. Now all of that combined is giving you a lot of that head rotation, lateral bending. Firing them bilaterally or unilaterally is going to change that coupling that's created in and around the joint structures to give you the mobility that you have. So if you so desire, you guys can switch spots and massage the neck of the person next to you. But that was all. So you want to go over the back? Why don't you guys do that? Then we can go finish up with the abs.
Don't get big face.
So get them to shrug your shoulders so you can find that trapezius muscle pop out. Find the spine of the scapula where it's inserting into. And then you can track that all the way up into that laminar groove as it goes and inserts into the superior nuchal line on the occiput. So again, C6, C7 down as far as T3 or so, you're going to have the Spinalis Capitis muscles come off at an angle and go lateral to the insertion point, well, to the superior origin of the trapezius. So where it originates off that superior nuchal line in the gutter. Just to the outside of that, you have that Spinalis Capitis coming up and inserting into the occiput as well. It should feel a little different in terms of location. It should be a little more tender for your patient to kind of have pushed on. Good. Okay. Now deep to that, we've got semispinalis capitis. Deep to those, we have suboccipitals. She can take a nap. We good? All right. So abdominal muscles. 4 layers of abs. External oblique. Now, paying attention to fiber orientation on your abdominal muscles helps you kind of understand their primary role and function. The most superficial being your external obliques. They're starting along the fascia and the rectus abdominis that goes across the top, and they insert out into the ribs. And if they fire, they're pulling the ribs on the ipsilateral side towards the midline, which means that if it's here and coming out to here, then when it fires, it's pulling me down and in. So it's creating rotation. It's pulling me across. So Russian sit-ups where you're doing the V-sits and going side to side, that's working these externals quite nicely. Your internal obliques underneath that kind of go from that iliac crest and up into the line. So these guys are firing, your internals fire to prevent rotation. So they eccentrically contract to slow you down or to prevent movement at all, which is a whole lot different story. So take somebody who's working on, let's take basketball. Basketball, you set a pick. You stand here, somebody comes charging through, they tend to hit your shoulder. You've got tight abdominal muscles, then when they hit your shoulder, these derotation muscles, transverse abdominis and internal oblique, they fire and they prevent me from bending away. They keep my upper body connected with my pelvis. So that if you hit, then you're pushing through all of my body weight because it gets all connected. This is not firing. You get hit and you twist and bend. Take that into football. They run, they hit. If they don't have a strong activated core, then it only takes about half of the same load to bend their upper torso to get them to lose their momentum. They have an activated core, and they're hitting with their whole body through because they're not going to twist to deflect the blow. So core strength has a lot of influence. The other piece is that it's going to be, again, with that anchoring of the pelvis into the upper body, it makes the pelvis stable as a base from which other muscles are acting. It's very hard to have engaged activated glute medius if the core is all squishy, wobbly, and unactivated. So somebody who's got patellofemoral knee pain, somebody who's got IT band syndrome, where the knee is kind of, the stabilization at the hip to control the knee's position is kind of all wonky and out of there. Until you work on core activation, it's hard to get those problems to resolve because those muscles can't work on an unstable base. These muscles create a lot of that stable base. Rectus abdominis runs across the middle. And remember, if you overlay where external obliques was, it was kind of coming from this point out here. It's really kind of grabbing the lateral margin of this muscle before it gets into the central line, which is a landmark known as the linea alba, the white line. So this is your six-pack abs. Some people call them washboard abs. Mine currently have a lot of laundry on them. You do six-pack abs, and some people have a keg. Whatever you want to say. Your abs. Ones that are superficial. The transverse abdominis, again, a derotation muscle. And these fibers are running sideways. So they're banding together to kind of hold everything in and connect it in towards that linea alba. So we start talking core activation, and it really is taking these deeper muscles and helping derotate the body, help control its movement and prevent motion. So, something cool we can do on palpation. You want to feel something really fun and weird? Yeah? Volunteer? Volunteer? You, okay? Rachel's volunteering. All right. Touching your stomach, okay? All right. So, get your person to relax, and they can't be laughing and giggling because it's going to contract the abs. But if you get the abs to relax, then palpate in. See your hand? Put your fingers right where mine is. Just relax. Just hold it right there. That's your hand. I feel it.
Whoa. You
can feel the thoracic aorta. You can feel the pulse of the thoracic aorta through the stomach. Fun? You want to try? Good? So right here, in the album, so belt line is right there, so we're going to come right here.
I feel like I
Put
can.
your fingers right where mine is. Right in the middle. And you're going to kind of push a little deep, but just all of a sudden.
Yeah, I feel
Yeah?
like pulse.
Yeah. You can feel the pulse of your heart, the thoracic aorta, which runs along the anterior part of the vertebral body. So it's deep, deep, deep. But you can feel it reverberate.
Am I squishing to do that?
Squish deep.
What am I squishing?
Small intestines. So large comes up and around the outside edges, and so this is largely small intestines. So you're kind of squishing through that 20 feet of small intestines. And the greater omentum, which is the fat pad that covers everything on top. So from that point, that artery drops down and then it splits right about that point, about the belly button as it enters the pelvis. Then goes medial and lateral and becomes the femoral artery. You feel it on yourself? Now, anytime you're taking a pulse, just strong reference, strong reminder, never take a pulse with your thumb.
Because there's a pulse in your
Because your thumb has a strong enough pulse that it can distract from what you're actually doing. So take it with your first couple of fingers.
Then you feel it jump.
Yeah. I'll just jam my thumb in your neck. It's fine. All right. I'm going to call it at that point to where we leave it there. Okay? We have head and face structures to worry about. Settle down now. So we've got head and face. It's going to be eye structure, ear structure. We're going to do cranial nerves, Dolan's lines. And then we'll do the muscles, well, the joint function of your TMJ, of your temporomandibular joint, your jaw. The muscles that control those motions, and then we'll do the respiration muscles for ventilation to finish off our thoracic cavity. And that's the segment that we get into for our final, for the second exam. So again, it's going to be kind of, there's hip and pelvis, and then there's spine and the muscles that work on it. And then there's neck a little bit with face and eye structure and ear. So it is a little, it's not as much intense detail, but it's pocketed information sets, which typically, again, grades are a little higher on this test because it isn't all of the origin insertion to that extent. But then it does throw some people for a loop just because it is completely what it feels like detached information. Sort of. So we'll get there.